Good morning, everyone, or rather a good afternoon. Welcome back to the Faculty Insight series. Today we have with us Professor Thomas Philippon from the Department of Finance. He's going to talk to us about optimal strategies to mitigate a pandemic. Professor Philippon has been right at the forefront of this research. Within a very short period of time, he has quickly identified how to use some of the epidemiological models and merge them with some of the important economic frameworks in order to get at some of the issues of optimal mitigation strategies. I would also like to put a plug in for Thomas' excellent book that has recently come out. It's called The Great Reversal. And it talks about how free markets in the United States have likely given way to greater concentration and perhaps economic rents for the incumbents. He does it by contrasting the American outcomes to those in Europe. It's a highly thought-provoking book, and I recommend all of you to look at it in your free time. Over to you, Thomas. We can take questions after your presentation is done. I'll curate them for you so you don't have to worry about the Q&A or the chat room.
Well, thank you all for being here. I hope everybody is safe. This is joint work with Callum Jones, who is our former student and now at the Board of Governors in Washington, and Venki, who is our colleague in the Econ department. So, as Viral mentioned, the motivation for us was really to think about a way of integrating the standard model of epidemic into a standard model of macro. And the reason that I think it's important is because the standard model of epidemic allows you to keep track, at least in theory, of how the epidemic is evolving. But it does not allow you to think about the trade-off between economic and health outcomes. So that's what we want to do. So we're going to do it in a standard macro model where people choose their consumption and labor supply. But of course, the key thing is they understand there's an epidemic going on. Therefore, they understand that some consumption and some and going to work can be risky in terms of infections. So what they can do is they can stay home. That is, they can reduce the purchase of some goods and services. They can stop traveling. They can stop going to the store, at least not as often. In terms of labor supply, they can work from home as well. So we'll show that this is actually an important factor. And then the thing we want to understand is, first, what are people going to do by themselves? And then the question is that enough? And if not, why? How big is the gap between what would be socially desirable and what people would do by themselves? So we'll characterize the private and social incentives, and then we'll show that the social incentives are much stronger and much more front-loaded. In fact, we can even find cases where the private incentives are perverse. And then we'll calibrate the model to get a sense of how steep the trade-off is. Of course, that depends a lot on the parameters, so I'll get to that in 1 second. But we find that the private sector by itself would have engineered a recession of something like 5 or 10%. But that would have been actually a very bad outcome because the hospital system would have collapsed. And in fact, if you wanted to avoid that, you had to push on the brake much, much earlier and more strongly. And so the planner solution calls for a slowdown in economic activity of something like 20 or 30%. So something like 2 or 3 times more than the private sector. So let's try to understand what's going on. Okay, so the model has 2 parts, or the paper has 2 parts. One is the epidemic part, the other one is the macro part. So the epidemic part is literally the textbook Epidemic 101, the simplest model you can imagine to model an epidemic. Okay, so it's SIR, that's the name of the model, and it's we just add a few things, such as we try to distinguish a bit people who are sick and not sick among the people who are infected, and then I'll talk about congestion in healthcare later. But apart from that, it's the standard model. So you can be susceptible infected, or you can be neither, which means that either you've recovered from your infection or you've died from your infection. So the last two, recovered and dead, are absorbing states. Once you get there, there's no coming back. In this calibration, okay, that a very critical question for policymakers is whether R is really an absorbing state. Whether that we don't know yet, but here I'm going to assume it is. So I'm assuming that if you've been exposed and you've recovered, then you are not susceptible anymore. Okay, so then the pool of susceptible people, initially you can think of it as it's everybody, or mostly everybody, or perhaps everybody who is not a child. So you could think of the susceptible population as like population between age 10 and, with no limits. I think in the model, we're not going to make this kind of subtle distinction. So we're going to imagine a situation where essentially everybody is susceptible at time zero. And then the number of susceptible people goes down as the number of infections goes up. So the number of infections is given by this function beta EIS over n. So what is this? So that's like a random matching model with quadratic matching function, which really means that it captures the idea of random interactions, not directed search. So he has 4 pieces. Beta, it's a parameter that is specific to the virus. It's how easy is the transmission conditional on a given contact. So for beta, for us, is a structural parameter that nothing can change. What you can change is E, which is the exposure. If you stay home, if you wear a mask, if you wash your hands all the time, you're going to lower E. In the baseline SIR model, E is fixed. It's like a number people take. Of course, in economics, the whole idea is going to be E is endogenous. That's going to be the key variable that we want to understand. So beta E is like infection rate times number of times the density of interaction, and then you multiply by the random matching part, which is the number of people who are infected, IT. So each infected, you can think of it as everybody who is infected. So anybody who is in the category IT is going to meet ET people per unit of time. So ET-IT is the number of meetings that involves one of these infected people. Now, some of the meetings are going to be with other infected people or with recovered people, in which case nothing happens. It's only the meetings that take place with susceptible people that can lead to an infection. So therefore, you want to multiply ET-IT by the share of infected people in the population, which is S over N. N is just the number of people at the very beginning. So N is initial population. S over N is the fraction of susceptible. Okay, so therefore ET-IT ST over N is the density of meetings between somebody infected and somebody who is susceptible. And then you multiply by beta, which is transmission rate conditional on the contact, and then you get the number of new infections. Okay, so that's the baseline model. Notice here that it's perfect mixing, so we don't assume there's different groups of people. All of that could be extended to multi-sector or multi-groups, but this is the simplest model. And number of infected, of course, goes the other way. So number of infected today is the number of infected yesterday, plus the new infections that we saw, beta E IS over N, minus people who leave the state, the infected state, either because they recover, that's gamma times I. So gamma is the recovery rate. So we're going to calibrate all of that at the weekly frequency. So gamma is literally the likelihood that if you're infected today, the likelihood that you're recovered next week. And to give you a sense, gamma is of the order of 1/3. And then you have people who die. So here we're going to distinguish among people who are infected, people who are sick. Usually that's the cases that people report. Like a big discussion was people who are not symptomatic. So you can think of 1 minus kappa I are the asymptomatic ones, and kappa I are the people who are sick. And then delta is the death rate conditional on being sick. Okay, so delta kappa is going to be connected to the case fatality rate, which is the likelihood of dying conditional on being an active case or detected case. Delta kappa would be the infection fatality rate, which is conditional on being infected. Okay, and then recovered and number of dead, of course, they just cumulate these functions, right? So that's the basic model. So from this model, you get this kind of impulse responses. So suppose you start with initially 0.1% of the population infected. Okay, so I naught over n at time 0 is 0. So you seed the model with a tiny bit of infection. Well, it's not, 0.1% is not a tiny bit, so it's like a significant number already. Okay, so what happens? Well, initially, if you go back to my equation, when S is very close to 1 initially, then this equation tells you that S declines exponentially and I grows exponentially. So the first thing that's going to happen is the number of infected start to grow exponentially. So this is literally an exponential. At some point, so this is the stock of people who are currently infected, the stock of all the past infection, minus people who have recovered or died. And the number of new infected, so that's the new infected in that, the number of new people who are infected in that period, in that week, so it's all in weeks. So that peaks after 20 weeks in this calibration. And where 6% of the population, that's the fraction of new cases, okay? Now, what happens here? What happens here is that the number of susceptible people, which is on the left here, has dropped enough that the number of new cases is lower, okay? And if you think about the math, is pretty easy. When S is equal to 1 over R, where R is the basic reproduction number, then that's when you get the peak of that curve. So I think that calibration was for R not of 2, so therefore you get herd immunity here when S is 1/2, roughly, okay? That's what happens. Around week 20, only half of the population is susceptible. Therefore, if you look at this equation, the number of new cases is going to become flat, okay? And then it's going to start decreasing, okay? And then this is the number of people who, that's the total number of people who died in dashed line. This last thing here is the case mortality rate. So this is, you see this hump here? It's because we're going to assume, this is like Italy, if you want. This is literally calibrated on Italian data. This big spike here is because this is what happens if the hospitals get overrun. See, in the basic model, you would set delta to a constant. So that line would be totally flat. It would be literally kappa delta or rho plus kappa delta. That would be just a flat line. But if you think that delta is higher when hospitals are overrun, then that's going to create a higher fatality rate because people are not treated properly. And that's going to be, that increase, that spike is going to be higher if there is if the stock of infected people is very high, okay? Because then you don't have the capacity, you don't have the number of ICU beds, you don't have the number of ventilators. So flattening the curve is useful because you're going to lower this spike here. Okay, so that's the baseline. Okay, so the first thing I want to do is to show you the big issue, which is the parameter uncertainty. Okay, so the key parameter in this model are beta, kappa, delta, gamma. Beta is the transmission rate of the virus. Kappa is the number of people who show symptoms. So that's very ambiguous because you have mild symptoms, strong symptoms. I think in our model, it's probably, you want to think of kappa as people who have symptoms that are, of course, people who need to go to the hospital. That's very clear that these are very, very strong symptoms, but also people who are really sick, that they feel like it's probably more than a flu. I would count them as kappa. So that's an important number because in the data, sometimes we measure these people better. Delta is the death rate conditional on having strong symptoms. So delta kappa is the risk of dying conditional on being infected today. And gamma is the recovery rate. Now, gamma is actually the one that's not too hard to find in the data. I think the range of estimates for gamma is much smaller than for the other parameters. Because once a case is diagnosed, you can see, how long it takes to recover. And that number, there's a range, but the range is relatively small. So I think something like 1/3 per week, most people recover fully. I mean, if you're going to recover, you're going to be recovered within 2 or 3 weeks. I think that seems to cover all the reasonable cases. The thing that's completely hard to estimate is delta and beta. Okay, so the infection fatality rate, which is the one of the key headline numbers, is the risk of dying conditional on being infected. So for me, it would be delta kappa, but delta kappa is gamma. So gamma is the thing that pushes you the other way, which is the recovery rate. Okay, so this is literally the fraction of people who would end up dying in condition of being infected today. That number is very hard to estimate. Why? Because we don't know the number of infected people. Similarly, the basic reproduction number. So when you hear about R naught in the literature, R naught is what's the number of people that somebody who is infected today would contaminate over his or her lifetime if that person lived in a population where everybody is susceptible. So all you have to do is you count how many people they're going to meet, and then they're going to transmit until they recover. So that number would be beta over gamma plus delta kappa. That's the basic reproduction number. Now, initially, when we wrote the first version of the paper, based on the data we found from China and Italy, we thought that the right number was that the infection fatality rate, IFR, was 1%, and that R was around 2. This was sort of the common wisdom, the way we read it around like a month ago. Today, we know it's not true. We know that the numbers are different. And relatively good news to some extent. The best estimate we have of the infection fatality rate is 0.5%. So it's half of what we thought. But R naught is much higher than we thought. We thought it was around 2. In fact, it's 3.3. So these are the numbers I'm going to use are from this. There is a study in France by the Institut Pasteur where they calibrated the model on French data city by city, and also together with the famous cruise ship where everybody got sick and tested. So that gives you enough information to pin down. There's still a range of estimates, of course, but much more precise estimation. But we didn't know that at the time. And so why is it so hard to find out? So here's one thing. So here I'm showing you 2 infections. We start at a very low number of infection, but I'm plotting you 2 different things. One is, so the red line is the one that we thought was the reasonable one a month ago. So it's based on an R naught of 2 and an IFR of 1%. So R naught and basic reproduction number of 2. So that means one person, if you put one sick person in a population, she's gonna transmit to 2 people in addition to her before recovering. That's R naught of 2. IFR of 1%, that means condition of being infected, 1% people will die. That's the calibration we had 2 months ago. Today, as I argued, the new numbers point out that we should really have R naught of 3.3 and IFR of 0.5%. Can you tell them apart? Well, of course, if you can test, you would. But if you can't test, then you can't compute the first one, because the infection percent, you don't know who's infected. You're infected even less. Susceptible, well, you don't know because you don't test. So all you can count properly are the really critical cases or the number of deaths. But look at these 2 curves. See, the red and the blue, they are on top of each other for the first 4 weeks. So there is no way, by looking at this data, to tell whether you are in the, very quick contagion but not very deadly, or slow contagion but very deadly, because they're going to produce the same number of deaths at the beginning. After a while, they're going to start to diverge. Okay, so in the short term, it's going to look like that. In the medium term, if you have a high R, it's like time is going super fast, because the thing is spreading so much more quickly if R naught is 3.3 than 2, that it's going to peak much earlier. In fact, the blue scenario peaks after 10 weeks. The number of susceptible people eventually drops to, it's not exactly 0, but it's very close to 0. Why? Because herd immunity happens when SR is less than 1. So if R naught is 3.3, then that would happen when S is 1/3. So you can see here it peaks around 10 weeks. Around 10 weeks, S is around 1/3. Okay. But then, of course, it keeps going a little bit. So eventually, essentially, if R naught is 3.3 and there is no intervention, eventually everybody has been exposed, pretty much, which means that the death rate in the long run is going to be exactly 0.5%. Now, the red curve takes a lot more time to play out. Now, you would think it looks like the blue is worse, but that's not true, because in the long term, of course, the red one is worse because it has a higher death rate. So eventually, the number of people dying is much higher in the orange curve. So in fact, the orange is the more scary scenario. It plays out. So that's the one that I think most policymakers had in mind, which is something which is, it might not spread very, very quickly, but it looks like it's very deadly. I think what happened is we vastly underestimated the number of people really infected. So we are, I believe, we are a bit more in the blue world than in the red world. Okay. All right, so that's kind of, but to show you that it's very hard to know when you start what are the right parameters. So, so now I want to understand, faced with this kind of risk, how would a society react? So I'm going to plug in, so now I'm going to simulate under the numbers that I believe are correct based on today's data, which is the number from France or from the Institut Pasteur study. Okay, so IFR of 0.5% and R naught of 3.3. And then we're going to calibrate something on the case fatality rate when the hospitals don't get overrun that captures the Italian data. And that's going to be a bit pessimistic. And this calibration does not reflect what would happen in the US, but it's going to give you qualitatively it's the same, of course, and it's going to give you a good sense of what's going on. Okay, so what is our model? Well, our model starts from the baseline SIR. So literally the SIR block is the same, but then we add a model of behavior. And the model of behavior is straight macro. So it's an optimizing agent who looks ahead and thinks about consumption and labor. Okay, so maximizing utility, discount the future output rho. So here, just to be clear, we're going to assume that there is a chance of having a vaccine and a cure at the same time. And if that happens, then you go back to steady state. So then this parameter rho, the discount factor, is actually going to be very high. It's going to be something like 25% or 20% per year, because you price in the fact that there's a 20 or 25% chance that you're going to get a cure and a vaccine per year. Okay, so it's going to be a bit higher than the usual rho we have in mind. Okay, and then the utility is people like to consume. They don't like to. They enjoy leisure. And then the key thing, of course, is they take into account that there is a risk of death and a risk of sickness. So if you are sick, so remember, kappa I, people are sick, then you have a disutility of sickness, UK. And if somebody in the household dies, there is a disutility, UD. So, and this 1 minus D minus kappa I, these are people who are healthy, and therefore they can work and consume. So that captures the cost of disease, the cost of sickness, maybe also the fact that it seems maybe if you've been seriously sick, there might be some permanent effect. Actually, some data suggests that even people who recover, they might have permanent damage. So that would be like in the UK parameter, and then the UD parameter, literally that's the statistical value of life, but that of course includes the psychological cost borne by people who survive. So that's going to be a large number. And then people decide to work. So there's a labor supply only for people who are not sick. And then we're going to assume that there's a work from home. So that is, work from home for us is a technology that allows you to keep working while not being exposed. But it's going to be subject to learning by doing, which is the first week is going to be a disaster. And then after a couple of weeks, you're going to figure out how to take care of the kids. So my kids now are on their computer there, so I can work. The school has become much better at giving them, instruction that they can follow by themselves. The parents don't have to be always behind them to monitor them. So this we think of learning by doing. For businesses, of course, is figuring out what can safely be done remotely, investing in the right software for the conferences, investing in the right. I think a lot of it also is safety, because many businesses who run critical infrastructure, they don't have the same level of cyber protections when people work from home. So they need to invest to ramp up their IT systems so people can work from home safely in the sense of cyber risk. All of this, for me, I think is of it as learning by doing, which is initially it's a bloody mess, but after a while, people figure out how to do it. Okay, and then the key thing is this exposure, ET, right, at the end. So in the basic epidemic model, ET is a number or parameter. In the macro model, ET is the outcome of choices. So people choose how much to consume and how much to work. And they understand there is an exposure effect to it. So here, ET is going to be the sum of three parts. One is social interaction, not related to market work. Then there is shopping, traveling, so consumption of goods and services. And then there is working. Okay. And then working is mitigated if you work from home. So M is the mitigation from working from home. Okay, and that's it. And the learning by doing we model in the standard way, which is the productivity loss when you work from home goes down when you practice. Okay, so the math is relatively straightforward, and then we can simulate the solution of the model. So let me skip the calibration. The numbers, the big numbers where we don't know is the parameter of the infection. Even surprisingly enough, even the macro is actually not that hard to get. You get data on the kind of output drop we see in China, in Europe. It's very easy to get the right ballpark. So I don't think there's that much uncertainty about the lockdown. But the big uncertainty is about the parameter that I showed you earlier. So now I'm solving the model in the case of the parameter that are today, the ones that I think are correct. So that's R0 of 3.3. So what people do, so blue is under the exogenous infection model. So that's the model where people don't understand that their behavior affects their risk of infection, or they do, but it has no impact. Okay, so that's the exogenous infection. So under exogenous infection, their behavior doesn't change. You can see exposure, E is blue, is 1. So that literally would simulate the model we saw earlier. There's a tiny bit of change of labor supply. That's because when somebody is sick, people who are not sick are going to work harder to compensate. That's why you have this tiny bit of change here. But they don't do it because they want to change the infection. Just do it because they want to make up for the lost income for people who are sick. That's this tiny change here. But the exposure doesn't change. Therefore, the SIR dynamics are exactly the one we saw earlier. Now, if you don't have work from home, this is the output would drop by about like 20% because people would stop going to work to a large extent and they would cut their consumption to limit their exposure. So you would have a private recession of something between 10 and 20%. If you have working from home, then what it does is the recession gets much milder. Why? Because you can cut your exposure while still working. It's not as efficient, so there's still a drop in output, but it's much better than not doing anything. And so that allows you to limit the drop in GDP and at the same time decrease your exposure more. Okay, so that's what happens to the exposure. That's the labor. This is the working from home. So the people working from home peaks together with the crisis. I'll show you something more about the Lagrange multiplier later because I'll get back to that. So what's the impact? Well, it moderates. So the blue is the exogenous model. And then the yellow here, if you want, is the private response. So the private response cuts down the number of infections quite a lot, actually, almost by half. And if the outcome is at the end of the day, the number of people who end up dying is maybe something like half of what would have happened if people didn't react by themselves. Okay? The problem is that the peak infection is still very high. Now, these numbers are more calibrated for like a big, like an infection that starts relatively high. So it's something you realize a bit late. So that's more like for Italy. But it's saying that at the peak, you have maybe 20% of the population who is infected. And that means that even if not everybody gets sick, of course, there's enough people who are sick and need critical care that the hospital get overrun. And you see the big spike in the number of people dying because they don't get the care. So the death rate is higher than it would be. That's because of the congestion externality in the healthcare system. So bottom line, people would do something. There would be a recession in any case, but it would not be enough to protect the healthcare system. So now what would the planner do? Well, the planner would do something a bit similar from private agents, but he would do it more quickly and more strongly. So the planner, so the blue is still the exogenous case, but now red and yellow are the same exact technology. So you have work from home technology or not, but it's solved from the perspective of the planner. So what you see, the planner pushes on the brake much more strongly. So now the recession is between, instead of being around 10 to 15%, now it's between 20 and 40%. Okay, so without work from home, the planner would have to slow down the economy to like 40%. With work from home, it only slows down by about 25%. People, in fact, in this economy, many people actually work harder because working from home is not that efficient. And so to compensate, you actually work more. So the labor supply at home is actually going up a lot. Total labor supply is still going down because people some just cannot work. So of course, if you don't have the option of working from home, that's going to drop. But the planner uses working from home a lot because it knows that it's a way of protecting the economy, and also it starts very early. So the planner does what we did at NYU, or I think many universities did the same. Like the week before spring break. In fact, we started teaching online with Zoom, even though we didn't have to, because we wanted to, be ready for after the break to be able to teach. Right? We wanted to figure out the bugs early on. This exactly is what I mean by learning by doing. And the planner does that. The planner starts working from home very early, even though at the beginning, the peak infection is not there. So the gain in terms of slowing down infection is not that high at the beginning. But the planner starts early because he wants to be ready for when the peak infection comes and be efficient at working from home. And then in terms of outcome, the planner reduces the number of people who end up dying by another factor of 2 compared to the private sector. That depends on the parameters. But roughly speaking, you can think of it as, if people didn't do anything, the death rate would be very high. Private response would cut that in half. The planner would cut that by another factor of 3 or 4 or 5, depending on the exact parameters. Okay, so that's the key thing. Now, why is it that the private sector response is not strong enough? Well, so there are a couple of key features. But the first one is, if you think about the SIR model, from the perspective of one household, you take as given, the key is that you take as given what others people do. So when you think about your own behavior, you think about the impact of your own behavior on your risk of infection. That's only half of the problem, okay? Because the other half is not you getting infected, but you infecting others. So literally, if you have a random matching search model with a quadratic search, literally the planner has a multiplier which is twice the private sector, because one takes the derivative with respect to one term, but the planner takes derivative to the term squared. So there's going to be a 2 there. So the planner is going to have 2 in all of its first order condition. And on top of it, the planner is going to be thinking about the value of infection over time quite differently from the private sector. And this is what I want to illustrate here. So when you solve the model in the background, you have a bunch of value functions. The value of being susceptible, S, and infected, I, okay, relative to recovered. So of course, these are negative because it's better to be recovered. But this is how they evolve. On the left, you have the equilibrium. On the right, you have the planner. So the equilibrium, VI is a straight line here. This is actually always true. This depends a tiny bit on some of the small details of preferences, but by and large, VI is flat. As long as the hospital system is not overrun. Because if the hospital system is working properly, then the risk of dying does not depend on anything else people do. So the value of being infected is essentially constant over time. That's what you see this red line being constant. What's the value of being susceptible? Well, initially it's 0 here, which means it's the same as the value of being recovered if there is no infection, because if there is no infection, there is no difference between S and R, because there is no risk. The perverse thing is you see infection start at period 1 here. So initially, VS drops in the private sector. VI doesn't change because the risk you bear from being infected doesn't change, whether as long as the hospital system works fine, that's a flat line anyway. So the blue drops, the red doesn't move. The blue minus the red shrinks, but the blue minus the red is exactly your incentive to be prudent, right? Because the incentive to be prudent for a private individual is the blue minus red. That's exactly what gives you incentive to limit your exposure. So what's very bad here, it starts by going down. And that's exactly the wrong thing, right? It's going down. That means people are less incentive to be prudent initially. And in fact, the worse the epidemic, the less. Why is it? Well, it's because if you think about your behavior as a private agent, if the epidemic is bad and there is a high chance you're going to be infected anyway, why bother, right? If the question is, you're going to be infected today or tomorrow or at some point, there is not much difference between being infected today or being infected in 6 months. Okay. If you think eventually you're going to be infected, the reason to be careful are very small because you're going to get it at some point. Okay. So that's why you see the blue curve going down, and that's why the incentives to be prudent are lower. What about the planner? Well, the planner agrees that the blue curve goes down, obviously. That has to be true. But the planner, in the planner's case, you can see the red curve drops a lot. Why is that? Because the planner for the planner, this is the value of somebody being infected. That's the sum of this one, which is the value, because if I'm infected, I can get sick or I can die. But the planner adds to that the fact that if I'm sick, if I'm infected, I can infect other people. So from the planner's perspective, this drops a lot. So the planner, in fact, blue minus red goes up initially. Okay. So the key thing here is that blue minus red goes down for the private sector, but it goes up for the planner on impact. Which means that if you think about the gap between what people would do by themselves and what the planner would like them to do, that gap is going to be maximum early on in the epidemic. That's where there's a maximum tension between what people want to do and what the government would like them to do. So all the political economy issue, all the issue of convincing people to do the right thing, it's all going to be very, very acute at the beginning. Now, there is even a case. Now, so this is the top line, the top figures is when the case where there is no risk of the hospital being overrun. Now, what if, okay, that's not realistic. So what if we bring the Italian risk, the risk that the healthcare becomes overrun? Does that help? No, in fact, in this calibration, it has the ultimate perverse effect. You see, it's still the case that blue drops a lot.
So the key thing here you see is that the blue is below the red. Now that's not a bug. It's actually true. Why is that? Well, that's the ultimate perverse incentive, which is if you think the hospital system is going to be overrun in a few weeks, then in fact, it might be a good idea to get sick today. Because if you get sick today, you're going to be sick before the critical mass, and therefore, you're going to get better care. So in fact, in that case, the private agents have the opposite incentive. They have an incentive to become sick quickly. Now that doesn't last, of course, because once the hospital is overrun, it becomes very risky. But that's to show you that, again, what you see is this very acute tension early on between the planner and the private outcome. The planner reacts the way you would think, which is if he knows the hospital system is fragile, then he's going to freak out and his VI is going to drop even more, and he's going to have even more incentive to impose a lockdown. Okay. All right, so that's it. That's what I wanted to show you. The key things are uncertainty about the parameters of the disease. That's a first order issue. That's why testing is so important. Second thing is private incentives are too weak, and also the timing is wrong. So you want to, there's a need for a strong intervention by the government. The numbers that come out of the model, if you calibrate it naturally, are exactly in line with what we see in the data, which is private respond in the range of 5 to 10%, optimal slowdown of the economy in the range of something like 30%, which is pretty much what we see in Europe today. Now, what about going forward? The thing that's important is that this maximum tension where people don't have privately the right incentive, it gets better over time. See, when the pool of infected people is higher, the risk is more present. It's still true that the planner would like people to be more careful than they would by themselves. but that tension is diminished. So you can hope that the exit from the lockdown can be much more decentralized than the lockdown itself, because it's not the case that you can fully trust what private donor would do, but you can trust them to a much larger extent than in the initial phase. Thank you.
That's great. Thank you, Thomas, for a very clear and excellent exposition of such a nice building block to analyze the optimal mitigation strategies. Let me start with a question by Yakov Amihud, our colleague from the finance department. Yakov's suggestion is that one can model the rising fatality rate when hospitals are overwhelmed. He refers to the models of Carlo Favero at Bocconi, who's calibrated it to Italian data. The model is that there's a constant fatality rate up to the hospital's capacity and a rising rate thereafter.
Yeah, that's exactly what we do. We use his numbers and his calibration.
Yeah. Okay. Thank you for clarifying that, Thomas. The next question is from David Yermak, and he's asking if you have compared the recent hospital experience in New York City and New Jersey to what has happened in Italy, just in terms of anecdotal data abounding.
So I saw some people doing that, and clearly in the hospital it doesn't look as bad. It doesn't look like, as of now, as far as I can tell, it doesn't look like the congestion in hospital and therefore the excess mortality in hospital is as bad in the US or in any other country as it was in Italy or Spain to some extent. But there's a lot of discussion exactly how to interpret the data. So I think we, like countries report. So who gets to the hospital versus who stays home? One thing very important is the Italian data is actually, the Italians are pretty conservative in the way they report. So they count people who die at home, people die in the hospital, and people who die in retirement hospices. So that the number look high in part because of that. So if you want to do an apple-to-apple comparison, you would really need to add also non-hospital death, and countries don't do it in the same way. But I think my sense is even if you do this adjustment, it was still much worse in Italy than in the US.
Thank you, Thomas. There's a question again on the data itself from Larry White. He's asking you to spell out a little bit more the fatality rate assumption that you have for the reported cases for the US. His quick calculation is that around 1 million infected in the US so far, with around 50,000 deaths. And so he's estimating the fatality rate to be 5%.
No, so the number we use is 0.5%. So that's conditional on being infected, the likelihood that somebody would die. But that takes into account the fact that many people who are infected don't know it. So that's the critical thing is the censoring, that you can sort of count the number of people who, the death rate, but you have a very, very noisy estimate of people infected. So in the US, I think the number of people infected is a guess. So that's why the data for that we use from other countries, the countries that have more like systematic testing.
Let me throw in one question from my side, Thomas.
Just
sorry, go ahead. Yes,
it's very important. Just in the data, the people report two very different numbers: CFR and IFR. CFR is case fatality rate. That is, given that the case is identified as COVID, what's the fraction of people who end up dying? And then IFR is out of the total people who are infected. The IFR you never observe. You have to get it from, you have to infer it. CFR is based on actual cases. So that's much higher, obviously. So CFR, it's probably, that's much, I mean, conditional going to the hospital, the number of people dying is probably like 10 or 20%. Conditional being very sick, it's maybe 2.5%. Conditional being infected, it's only 0.5%. Okay. Yeah.
Yeah, and to just clarify what Thomas just explained, Larry, I think we have friends who are infected but who are not in the statistics. And I think that's what Thomas is referring to. They are not in the cases that are officially reported, but we know that they have COVID symptoms and they would be counted in his infection rate calculations. Let me jump to a slightly different question. You hinted towards this at the beginning, which is, and Larry White has also touched upon it. So clearly some of the parameters such as the risk of fatality upon being infected is highly different based on very well separable groups of people, say by age, for example. This also relates to those who are contributing the most to economic activity in terms of work contributions. Of course, the elderly might also be consuming and therefore contributing to economic activity. So have you thought about how one would sort of rewrite these models and what sort of externalities might arise? Because some work that I received just 2 days back from Adriano Rampini was essentially recommending, based on this observation, that something like a separated lockdown where you essentially have elderly being quarantined and the younger being able to work at their offices may actually achieve the efficient trade-off. And it's actually even efficient from the standpoint of economic activity as well as from the standpoint of spreading of the disease.
Yeah, so I think there are two different questions. One is it the case that any optimal solution would involve differentiated solution by age or health status? I think that's the answer is yes. There is absolutely no doubt, because there's so much heterogeneity in the health risk between. It's so non-linear with age that it's obvious that there is no sensible solution that does not involve discrimination along the age dimension. I think that's kind of obvious. Now, then whether it's strong enough that there is a subset of the population for whom the private incentives would be pretty much aligned with the social incentive, that depends a lot on the parameters. It's not impossible. It's not impossible. It's clearly possible for people who are recovered. So that's why there's this issue of, if you've been exposed and you've recovered, then you can't get sick and you can't transmit that. Then in theory, you have zero externalities. So you should just do whatever is good for you. I think that in Sweden, for instance, they haven't locked down the economy, and they've advised, I think, older people to stay home, but it's not compulsory. So to me, the tricky question there is really, it is optimal for sure to discriminate along the age dimension. And the big question is, should that be a requirement or an advice? I think that's a tricky question. I find quite, I don't know, I think it would be, it would seem a little bit too paternalistic or too extreme for me that the government would require older people to stay home. They could advise. Plus, if you think about it also, older people, they are not the ones with the strongest externality, because they are very at risk. And we are worried about younger people infecting older people, when not so much the other way. So older people, I don't think that the externality is very high. So the case for making something compulsory for them is weaker. The case for making compulsory changes to younger people so they don't infect the older ones, that case is much stronger.
Right. Thank you, Thomas. Let me ask one other question. You touched upon the model uncertainty part of yes, how uncertain these parameters are, and that seems sort of really a challenging issue, even from a personal experience. So clearly, having gone through, say, most individuals who have gone through this over the last 2-3 months, have themselves been updating their priors on, what they see as the spread of the disease in their immediate vicinity. You look up the numbers at the CDC or any other website. One question I have is, is it possible that with some sort of adaptive expectations where, individuals adapting more to the recent outcomes, that at certain stage of the curve, you actually get a reverse, you sort of the externality reverses, so to speak, which is that precisely when the curve starts declining, because the recent past has actually been pretty bad, you get a fair bit of reluctance in people to actually start consuming and start actually relaxing the lockdown on their own. Whereas in the early phase, you have the externality that you were just mentioning.
Yeah, that's possible. So to me, the thing we're working on now is to try to figure out how does the policy look like under uncertainty. And then you have two types of uncertainty. You have micro uncertainty and macro uncertainty. So you have, what would people do if you told them their status? So in my model, maybe I should make that clear. In my model, people don't know if they are sick or you can only imagine the small fraction of people in my model who got really sick, so that they know that the symptoms they had couldn't possibly be the flu, and then they recover. Then you can plausibly assume these guys know their status is recovered. But I think that's a tiny fraction of the population, so it doesn't matter. So all the agents in my model have no idea. They don't know if they've been exposed or not. So I think that's the realistic benchmark. So it's maximum uncertainty. Now the question is, suppose you bring in tests, then what happens? Is it good or bad? Well, it's if it's testing, if it's a test of whether you're infected or not, it's not obviously good, because people could have the wrong incentives. In other words, if you know you've likely been infected already, then you might be the one who should go shopping, because that would not increase the risk of infection in the family that much, because you probably have been infected already. So if your prior is somebody, if somebody has been infected or has a higher chance, because we never know, then that might be the one you want to send to the store. And so in that case, giving them more precise information about their status could actually increase the pool of infected people engaged in social interactions. So now, of course, if you can do a test together with a quarantine mandate, that's different, because then you don't have a choice. You do the test. If you come up positive, then you are required to stay home for 2 weeks. So that's so the first thing you realize there is that a test should be attached with some requirement, because you cannot expect necessarily people would make the right choices. And if you look at countries that do that, Korea, for instance, that's what they do. Like, if you've been tested positive, you're required to, and they monitor you actively, and there's a huge fine if you are found outside your house in less than 2 weeks after a positive test. So they don't trust. You might argue people would do it because of altruism. That's probably true, but I think it's, on top of it, they put some strong punishment for not doing it. Now, so that's the micro uncertainty, and I think it's true that exiting the crisis, I totally agree. Like, we're going to have plenty of externalities, plenty of aggregate demand issues, local demand, relative demand, stuff like that. And people are going to be reluctant to start consuming the way they did if they don't know their true status. So I think in that case, clearly, testing could have an impact on, it would be like reducing uncertainty and reducing precautionary savings. So that would be like a good macro outcome. To me, the most important thing with testing, though, is not the micro uncertainty, is the macro uncertainty. Is the fact that you don't know the state of the system. And even today, we don't know. We don't know S in the US. We don't know I. We have some idea that maybe 20% in New York City, but that's very, very, like, look at this publication, the standard errors are gigantic. So, and as a policymaker, that's the thing, that's the most important data you need. So to me, the most valuable part of having a test is to estimate the social distancing or the precaution that actually work. Like, so the key thing would be, say we reopen. So we're going to reopen the school up to some age. We're going to reopen the public transport with some requirements. We're going to tell everybody has to wear a mask. We're going to tell people cannot have lunch together. Maybe we're going to have like 20 of these policies like that. And they're all costly. And we have no idea which one has an impact on the transmission. So if we want to estimate what are the right policies, then we need to be able to map these actions, these policies into changes in the infection rate. And you can't do that if you don't have testing. So to me, the most important part of the testing is that it allows you to keep track of what's going on. So you can estimate which policies are useless and which policies are useful. And even more importantly, you can do risk management, because you need an early warning that if you miscalibrated your exit from the lockdown, and then you thought that masks were very efficient, maybe they are not, or something like that, then if you only have data on the number of bad cases, like I showed you earlier in the slide, then that means it's going to take 2 or 3 weeks before you become aware that something is going wrong. And 3 weeks in this world is a disaster. So you need testing, because you need to have real-time feedback. So you know that if your lockdown, if your exit is too quick and it's spreading more quickly than you thought, you need to be able to figure that out in real time. That, I think, that's by far the most important policy parameter.
That's great. Thank you, Thomas. Unfortunately, we are just out of time, so I'm not able to take the last couple of questions, but Dick Berner has prefaced his question by saying a great presentation, and I want to say encore to that. Thank you very much for introducing us to the sort of very fascinating work you're doing, linking epidemiological models to economics and macrofinance work. Thank you, Thomas.
Thank you.
Thank you, everyone. Have a good afternoon and stay safe.